what is the secret to a successful refractive surgery? I think the most important thing that you need to keep in mind would be appropriate selection criteria for your patients. So what is that one factor which defines your outcome of refractive surgery? The most important, or rather the only factor in my opinion, would be a good and a thorough pre-LASIK screening. Why is that so important? Because there's a saying which says that well begun is not only half done, but it's often fully cooked. So if you've picked up all your problems before you've begun the surgery, you're possibly more equipped to deal with them when they actually hit you in the face. Now, in your patient profile, you would like to look at a couple of factors. The age of the patient. You obviously don't want to have a patient that's too young, below 18 years of age, because he may have an unstable refraction. So you want to make sure that your refraction has been stable for at least over a year. You want to look at what are your patient's needs. Are they doing this surgery for cosmesis? Because yes, then you might want to address that. Very often we have patients who walk into my refractive practice and tell me that, doctor, I want to do the LASIK surgery because when I wear glasses, I get a headache. So once I do the surgery, I'll get rid of my headache. So it's important that you clear these kind of misconceptions before the surgery, because otherwise after the surgery, they're going to come and give you a headache that their headache is still not gone. You also need to address their associated systemic comorbidities, which often they do not reveal on the first visit, or if you are just asking them whether you have any regular health issues like diabetes, blood pressure. What I commonly face is that if you ask them, do you have blood pressure, they say no, I take a tablet and it's in control. So they have this belief that if you have a pill for it and it is under control, it's not a disease. So you need to make sure that you have taken their systemic history well, and you need to rule out contact lens induced dryness and intolerance to contact lenses before you plan them for their surgery. The most important out of this would be a motivated patient, because that's half the battle won. Once you have a motivated patient, it's very easy for you to go ahead with almost everything. In the must-dos, I would say my first would be the patient needs to be fully informed about the potential risks, benefits, and have very realistic expectations. So for this, I give a good chair time with my patient. I like to talk it out with them. I like to address any questions they have and discuss in detail what misconceptions they have. Always age over 18 years and a stable refraction. And the current FDA approval is, of course, myopia up to 12 diopters, hyperopia 6, and astigmatism up to 7. The most important must-do for you is you must know your patient, because if you don't know what you're dealing with, like I said, during the surgery, he's going to give you a hell of a time. So we check multiple things, which we usually check whether we're going for a regular LASIK or we're planning for a smile or anything else. Let's start with them one by one. First of all, in vision and refraction. Now, in the center that I work at as a refractive surgeon, after we do a regular undilated refraction, we subject the patient to, we have a wave scan aberrometer, so we subject them to a wave scan guided refraction, because we have seen that their readings collaborate very well with the patient's acceptance. And then we also do a cycloplegic refraction. It's very important to do this so that you've ruled out any cause for accommodation and false refractive errors. Topography and pachymetry has been covered by the previous speaker, so I'm not going to spend too much time on that. We have an scan at our center, but whatever diagnostic facility you have should be okay. Aberrometry, now, for example, if you are doing a wave scan or an aberrometer guided LASIK like we do, then you would need a machine that's linked to your own examiner. We do it on the wave scan. Of course, now there's also the eye trace and other aberrometers to guide you. A good clinical examination is always very important. You need to have good slit lamp evaluation. You need to check your intraocular pressure. A dilated peripheral retina evaluation is a must. I would like to give a moment here to stop here and emphasize on the importance of this, because many of us have LASIK centers which are referral centers where other doctors or other general ophthalmologists bring their LASIK patients to our centers to get operated, and for some reason they don't seem to see the need to dilate the patient, or they feel that kar do na doctor, just finish it off. But it gives you a heads up that you need to watch out for such patients, because as surgeons we need to draw a line and know that at some point, even if we've done everything well, even if we've done a good pre-op screening, we've got a good uneventful surgery, everything's gone good after surgery, some patients will always come back and say, but there's still some tricking, or but it's not that clear. Some patients are always going to be unhappy, and we as clinicians need to realize that we can't make everyone happy. With that, I'd like to end my talk. Thank you very much.
Thank you. Excellent. I've got a small couple of doubts. You mentioned in your first slide about the comorbidities, which you have to rule out. Can you just mention a few common clinical conditions which you like to rule out?
Mainly collagen vascular diseases because of their tendencies to scar. Especially if you are planning a surface procedure like a PRK, their chances of the haze and the scar post-operatively will increase substantially. So you want to rule out these kind of tendencies. Also, if you have a keloidal tendency, even if you're doing a regular LASIK, the flap morphology of the flap edge after the surgery, the way it heals, may be a little altered. You may have an altered response, which is why you want to always be careful. But because of that, stromal keratocyte with epithelial interaction going to be a little different as compared to usual. So mainly we're looking out for keloid tendencies and collagen vascular diseases.
I would like to add two more things. Experience. I have seen a couple of patients with subclinical thyroid disorders developing a lot of severe dry eye.
Yeah, absolutely.
I think my personal opinion is most of the patients, almost all the patients need refractive surgeries, so it should undergo a thyroid profile test.
Right.
And also, what is the opinion of the also about HbA1c and HIV tests?
So I just asked this question to a couple of people yesterday because I have a patient who is coming in with hepatitis C. So she's taking full treatment. I would like to throw this question open to everyone as well. She's taken treatment and she's in remission right now. It's been around 6 months. And now the question is, can she undergo LASIK or not? Can anyone over here help us with this? Would it be safe for us? Do we need to do a double autoclave? Or we should go for a surface procedure or a femtosecond because everything is disposable?
Dr. J.K. Reddy sir, can you please answer that?
Just like any other case? Okay.
Just like any other case. The only thing is the advice is our practice in India, the instruments the staff take and clean it. Instead of that, the instrument should be sterilized first and then should be cleaned. The disinfection also not very effective. Directly take them and let the instrument be sterilized, then clean them. So that it's only preventing contamination for the staff. That's all. But anyway, you said this is in remission, so it's mostly in the immuno-infective stage.
Right.
So it can be done like any other case.
Thank you so much.
Thank you, sir.